Good evening, everyone. Thank you for joining our online CME Live today from Gleneagles Hospital, Kota Kinabalu. My name is Lucy, and it is with great pleasure that I welcome everyone to our online CME Live event, especially to those who have followed and support us from the beginning. Today, we have Dr. Cheng Seng, our resident gastroenterologist and hepatologist, to share with us on the 4 things you absolutely need to know about fatty liver disease. Before we start, allow me to brief you a little of Dr. Cheng's background. Dr. Cheng has been in private practice since year 2001. He received his basic medical education at the University of Aberdeen and went on to train in gastroenterology and hepatology both in UK and Malaysia. He majored in therapeutic and diagnostic gastrointestinal endoscopy and subsequently completed his fellowship in advanced hepatobiliary endoscopy at the world-renowned Amsterdam Medical Center's Department of Gastroenterology. In addition to diseases of the gut, he also has a strong interest in the treatment of liver diseases such as hepatitis B and fatty liver disease. He remains an avid internal medicine clinician at Gleneagles Hospital, Kota Kinabalu. If you have anything to ask Dr. Cheng, please send it to the comment section, or you can WhatsApp your questions to the phone number as stated below, and Dr. John will try to answer your questions toward the end of our session. Without further ado, I will pass this session now to Dr. John. Good day, Dr. John.
Good evening, everyone, and thank you for joining us this evening. Really appreciate it, and really do commend you for joining us at the end of this long day. I myself had a long day, I'm sure you had too. So if you are here, just give yourself a big pat on the back for joining us. Really appreciate that. The other thing I'd like to know is, just to welcome you and to know where you're from. If you're from outside KK or outside Sabah, can you give me just a wave in the comment box, a thumbs up, so that I know where everyone is from? When I was approached to do this CME, this topic came very easily because fatty liver disease has become one of the commonest problems that I see. When I started out in private practice 20 years ago, most of the time liver disease, I will only see viral hepatitis. But this fatty liver disease has dwarfed all the liver conditions combined. So today, I've structured my talk to be very practical for you as a primary care physician, and I think most of you are non-hepatologists. But before that, I want to give credit here to Professor Chan Wah Keong of UMMC and his team for some of the slides that I'm using that he has posted on public site that we can borrow. And I want to draw your attention also to a most excellent webinar series done by the MSGH on their website. MSGH stands for Malaysian Society of Gastroenterology and Hepatology. You can find it on their website. So without further ado, let's get into it. Yeah. So what's fatty liver disease? Fatty liver disease, or non-alcoholic fatty liver disease, describe a spectrum of liver disease caused by a build-up of excess fat. The diagnosis is made after exclusion of significant alcohol intake and other causes of chronic liver disease. And these days, we know that majority of cases are closely associated with obesity and is considered as the liver manifestation of the metabolic syndrome. This liver damage can range from simple accumulation of fat called steatosis to non-alcoholic steatohepatitis or NASH. And this can mimic alcoholic hepatitis. It can also progress to cirrhosis. The progression of the disease usually goes from simple fat deposit to the scarring of the liver, called fibrosis, and eventually can lead to liver cirrhosis, cancer, end-stage liver disease, and death. There are many exciting new developments on NAFLD recently, but I want to highlight 4 important aspects that I feel it's that you need to know as a non-hepatologist and in private care, in primary care, as primary care physician. So NAFLD, the 4 things that you need to know. Firstly, it's a silent pandemic. Pandemic is a hot word these days. I don't use it lightly, but later on you will find out why I describe it as a pandemic. Secondly, it has a new name. And thirdly, so what's the big deal about NAFLD? Why is it important that we need to know about it? And lastly, and most importantly in fact, what you can do about it. So let's go. It's a silent pandemic. You know, NAFLD is a little known disease, yet a quarter, 25% of the world's adult population is estimated to have it. And in Asia Pacific, Latin America and Middle East having the highest prevalence. And you can see on the slide that in Asia Pacific, 27% of adult population, in the Middle East 33%, and Latin America almost again 1/3 of the population estimated to have NAFLD. The global burden of NAFLD is predicted to increase by 1 to 6% in these regions by the year 2030, which is not too long to go. In fact, NAFLD is the most prevalent liver disease in human history. You know, NAFLD is largely a silent disease. Majority of people having NAFLD exhibit no symptoms. They don't know about it, often unaware of its presence. As a result, the condition goes unnoticed and undiagnosed until usually a very late stage, leading to a worse outcome for the patient and a greater burden on the health system when they present. In fact, if you ask the general public, general awareness of the condition remains low, even among doctors and non-hepatologists. Recent research has shown that NAFLD is the liver-related manifestation of metabolic syndrome and is closely related with the other component of the syndrome, such as obesity and diabetes. And this figure shows that 23% of people with NAFLD has diabetes. Almost 70% has high cholesterol, and almost 2 in 5 have high blood pressure. And also more than half of people with NAFLD are obese. You know, in the last 4 decades, the prevalence of obesity across the world has increased 300%, 3 times, and is set to continue to rise in both the developed world and emerging economies like our country, which will only contribute to an increase in NAFLD in times to come. And this slide just summarize the various issues for NAFLD that we need to tackle. As I have alluded to, almost 25% of the adult population have it, and it's also associated with other serious non-communicable diseases, most notably cardiovascular disease and also chronic kidney disease. The other problems are thyroid problems, polycystic ovarian syndrome, obstructive sleep apnea, and an increased risk of digestive system cancers. Therefore, this patient will often present with other conditions at the same time, most commonly type 2 diabetes and cardiovascular disease, leading to the need for multidisciplinary disease management, and therefore it's associated with high and large healthcare costs and economic losses. In particular, NAFLD has become the most important indicator for liver transplant globally, with an estimate in the US alone, a pre- and post-transplant cost of over $1 million per patient. And it's often symptomless, as I've mentioned. Now, because of the low awareness in the public and even among non-hepatologists, no country has a specific strategy for addressing NAFLD and its implication, and even fewer have clinical guidelines or evidence-based care pathways in place. This condition is also rarely included in strategies, in national policies, in national guidelines for related conditions such as diabetes. As a result, no country is adequately prepared to manage NAFLD now and also in the near future. But the good news is that the majority of people diagnosed with NAFLD can be managed in the primary care setting with lifestyle modification that target diet and physical activities and behavioral change. Individuals with more severe disease can then be referred to specialist management led by hepatologists or gastroenterologists, but this represents a much smaller proportion of people with NAFLD. Research in Europe has found that multidisciplinary care is implemented in only 24% of European countries, and that the majority of care is still managed by hepatologists and gastroenterologists. The same research also found that follow-up and pathway to specialist referral from the primary care is only present in 17% of the countries, meaning that only in 17% of countries is there a clear guideline of how primary care practitioner can refer to a specialist hepatologist. Therefore, while it's important to raise the awareness of NAFLD among primary care doctors, it is equally important to support that awareness with two things. Firstly, we need to give you the tool and the information to assess the severity of NAFLD, and secondly, to identify those who will benefit from referral to specialist management, which I hope you will get both by the end of this talk. So let's go on to a second must know. A new name, well, sort of. I'd like to test your general knowledge. Who can tell me from which play by William Shakespeare is this quote from? A rose by any other name would smell as sweet. Well, if you have answered Romeo and Juliet, give yourself a pat on the back and consider yourself a William Shakespeare aficionado. The bard, William Shakespeare, is basically saying that the name is not that important. The name of a thing is not that important, but the essence of that thing is. But I can show you that in the case of NAFLD, it is actually long overdue for a name change. Why? Consider non-alcoholic steatohepatitis. Now, this condition was described over 40 years ago by Ludwig, but the terminology remains problematic because it is premised on a negative. That means it's excluding excessive alcohol consumption. But we know that these days NAFLD and NASH is associated with obesity and diabetes, and also with other chronic liver disease. So it needs a new definition of positive criteria, not an exclusion of negative. So in the year 2020, a group of experts led by Aslam proposed a new term called metabolic dysfunction associated fatty liver disease, or MAFLD, from NAFLD N to MAFLD. And this slide says it all. A new proposed nomenclature for NAFLD is metabolic associated fatty liver disease, or MAFLD. The major benefit of this new name is a shift towards a diagnosis of inclusion based on the presence of metabolic dysfunction, the key driver of the disease. And this quote is taken straight out of our very own Malaysian clinical practice guideline on diabetes. And it's among the first few guidelines globally to recognize and include MAFLD in its management in its guideline. I'm rightly proud of our endocrinologist colleague to be so progressive. In fact, it is now widely endorsed. It is endorsed by the Asia Pacific Association of Study of the Liver. It is endorsed by the Latin America Association, and again also in the Middle East and North Africa, and our very own Malaysian Society of Gastroenterologists and Hepatologists just last year. Now let's get to some practical point after the name change. So how do we diagnose MAFLD? So firstly, you have to have the basic fat in the liver, right? So the fat in the liver is detected either by imaging, usually by ultrasound, or the blood markers or the scores by liver histology. And then you need to have one of these three things. You either overweight or obese, defined as a BMI of greater than 25 in Caucasian and greater than 23 in Asians. Yes, it is that simple to be obese. BMI of over 23. And then you need to have either that or that type 2 diabetes according to international criteria, and or a presence of greater than 2 metabolic risk abnormalities. Any two of this. Either you have a waist circumference that is as shown in Asian or Caucasian men, where you have high blood pressure or on specific drug treatment, you have high plasma triglyceride, high or low plasma HDL cholesterol, you are pre-diabetic, defined as HbA1c 5.7 to I think is 6.3% these days. Your HOMA IR is greater than 2.5, or your plasma HSCRP greater than 2 milligrams per liter. And the sharp eyes among you will recognize that this red box they are actually the criteria for metabolic syndrome. So actually MAFLD is premised upon metabolic syndrome. In fact, that's a lot of your patients if you think about it. So again, a flow chart just to summarize that. You need to have fat in your liver, and then you need to be either overweight or obese, or you have type 2 diabetes, or you have at least any two of those metabolic risk abnormalities to diagnose to have MAFLD. The third thing you must know is, so what? Why is MAFLD important? Now, you will have noticed by now that I would be using either NAFLD, MAFLD, NASH interchangeably, because many of the slides that I'm using predates the name change. So if I say NASH or MAFLD, it actually means the same thing. So why is MAFLD important? This is the natural history of MAFLD, and you can see that the annual incidence, the liver, normal liver with simple steatosis will progress from simple steatosis to steatohepatitis and having fibrosis progression in 3 years. And fibrosis will progress one stage every 7 years in patients with steatohepatitis, one stage in every 14 years in patients with simple steatosis. And when you develop cirrhosis or even fibrosis, your chances of developing hepatocellular carcinoma is between 1 to 4% per year. You can also get HCC in the absence of cirrhosis, because absent cirrhosis reported in 30 to 50% of methyl-D associated HCC, but the absolute risk of HCC in someone without cirrhosis is actually quite low, less than 0.1% per year. Fibrosis stage is the single most important predictor of death due to liver disease. If nothing else, you must remember this slide, that it is all about fibrosis. And I want to show you here that if you have stage 1 fibrosis, what we call F1, it is your chances of dying is only about 1.5 times greater than those who have no fibrosis. But when you get up to stage 2, your risk increase to almost 10 times. And in stage 3, it's about 16 times. And when you get to cirrhosis, which is stage 4, you're over 40 times more likely to die from liver complication. So, why is methyl-D important? Because we need to have a paradigm shift that methyl-D is actually a serious end organ damage of metabolic syndrome, just like cardiovascular disease, just like chronic kidney disease. I'm going to show you some more burden of NAFLD. NASH has demonstrated the greatest increase and become the second leading cause of chronic liver disease among the new liver transplant waitlist registration in the United States. It's become one of the greatest workload generator. And NASH is the second leading etiology of hepatocellular carcinoma leading to liver transplant, and it's the most rapidly growing indication for liver transplant in patients with HCC in the United States. And all this serious liver complication will cause an expected increase in disease and health burden in the next 10 years. These are studies from 4 Asian cities, Hong Kong, Singapore, South Korea, and Taiwan, showing that there will be a steady rise in liver-related complication and death in the coming 10 years. What can you do about it as a primary care practitioner or non-hepatologist? You can do 3 things. You can screen, you can stratify your patients after screening, and you can refer them if necessary. What do you do at screening? Firstly, you've heard that it is so closely related with type 2 diabetes, so you screen all your type 2 diabetic patients. You screen all your obese patients, and you screen them for metabolic syndrome as well, those with cardiovascular disease and those with chronic kidney disease. So you can see these patients are actually very common even in your practice, especially in primary care setting. Obesity in Malaysia is so common. In the National Health and Morbidity Survey done 2 years ago, we found that 1 in 2 adult Malaysians are obese. 1 in 2. And 1 in 2 adult Malaysians are centrally obese. Oh, just a reminder that despite the strong connection with obesity, NAFLD or MAFLD can also occur in normal weight individuals, so-called lean NAFLD. And this is especially a problem in Asia. What about the prevalence of NAFLD in Malaysia? What study do we have? Again, Professor Chan's team in UMMC, they did a survey, and in 2013, they're just looking at individuals who came for a health check in their clinic, and they found that 1 in 5 patients, 22.7%, has got NAFLD, just ordinary seemingly healthy people who came for health check. Compared to young adults, I think they took a group of medical students and they found that the incidence, the prevalence of NAFLD in these young adults are quite low at 8%. And then when they contrast it with patients with diabetes, about half of them has already got NAFLD. A more up-to-date study from them using FibroScan showed that 57.4% of people in health check individual, just like the first group just now, seemingly healthy, has got NAFLD, more than half. And out of this, they detected almost 17.5% of people already develop advanced fibrosis. And if we look closely at the NAFLD in patients with diabetes, the blue bar here just shows that the reading CAP greater than 263 just means significant steatosis, which is another way to diagnose NAFLD. Over 70% of people, diabetic patient, has NAFLD, and 21% of people have significant fibrosis, shown in the LSM or liver stiffness measurement here in orange. Among patients with liver stiffness measurement greater than 8 kilopascal who underwent liver biopsy, majority, more than 80%, has got biopsy proven NASH, steatohepatitis, and some degree of fibrosis. And 87%, majority of them have got some degree of fibrosis, and of this, more than 1/3 has already got advanced fibrosis. Therefore, that's the importance of screening your most at-risk population, the diabetic and the obese patient. If I want to put a verse, a quote in your mind today, it's that screening is about detecting advanced fibrosis. And I want to remind you again that fibrosis is the single most important predictor of death due to liver disease, as I've shown earlier. So what can you do? What tools are available to you? The gold standard for detecting liver fibrosis is still liver biopsy. But these days, we have at our disposal a series of non-invasive tests for liver fibrosis and cirrhosis. I want just to draw attention to a few of them. We have this simple fibrosis score called APRI, FIT4, Fibrosis 4 Index, AST to ALT ratio. We also have specific fibrosis markers such as ELF, Enhanced Liver Fibrosis Panel, ProC3, which is related to the collagen, fibrometer, fibrotest. Some of these are available commercially, many are not. Imaging tests, of course, the easiest would be the ultrasound or the ultrasound elastography, vibration controlled transient elastography or FibroScan, 2D shear wave elastography, which is available in my own center. I'm using the 2D shear wave elastography. They are all called FibroScan for simplicity, but actually they use different modalities, but they both can detect fibrosis, or point shear wave elastography, and also magnetic resonance elastography if in more advanced center. So these are the modalities available to measure liver stiffness or elasticity. Firstly, the original FibroScan or transient elastography. Then you have the point shear wave elastography, 2D shear wave elastography, which as I mentioned is available in our center here in Gleneagles, Kota Kinabalu, and magnetic resonance elastography. So after all this, what can you use in primary care as a GP or a-- Again, I want to remind you, it's about detecting fibrosis. the simplest thing that you can do is to use a fibrosis score such as FIT4, NFS, or the Enhanced Liver Fibrosis Test, or EPRI. I'm going to show you an example of one of these scores called FIT4. In fact, FIT4 is quite easy to use. As you can see, you will need just 4 parameters: the age, the AST, platelet count, and the ALT. And it has been validated locally in UMMC to be very useful and very practical with a high negative predictive value. That means it can rule out liver fibrosis quite easily. So if you have a reading of less than 1.3, you practically rule out advanced fibrosis. If you have more than 1.3, you go into intermediate or high risk advanced fibrosis, which then you have to stratify and refer if necessary, but I will come to that. So apart from the fibrosis score that you can use most easily in your setting, which is the FIT4, coming soon will be things like PRO-C3, ADAPT or type 4 collagen used by the Japanese. All these are in various stages of development and hopefully will be available commercially soon, that you will be able to measure fibrosis directly instead of just using a score. And of course, you can use the modalities that I've outlined earlier to measure liver stiffness. A word about liver stiffness measurement. This is the unit in our center. It's a Canon Aplio i700 machine. It can do both ultrasound and also 2D shear wave elastography. And what we get is a reading like this. You can see that it gives elasticity value in kilopascal. The principle is that the stiffer the liver, the higher the kilopascal, the higher the value. So the lower the value, the more elastic the liver is, and therefore the less stiff the liver is. So you can see that for stage 1, F0 to F1, when there is no significant fibrosis stage, the kilopascal is less than 7.1, but it goes up to 9.5 and 10.5, and above 10.5 you consider to have cirrhosis. And this is a typical example of what we see in liver stiffness. We measure, we point the probe and we measure a part of the liver and get the measurement of liver stiffness. We do 10 measurements at a time, and we will get a median value, and there is a formula to make sure that the measurements are valid but not only valid but accurate for use. So you've heard about the fibrosis score that you can use in your clinic. You've heard about using modalities like liver stiffness measurement to aid in your screening. How then do we put them all together? How do you make decision who to refer, how to stratify? And this is a simple flow chart that I want to share with you. You start with somebody with NAFLD, then what you do is you use a fibrosis score like FIT4 or NAFLD fibrosis score to determine the risk of advanced fibrosis. If it is less than 1.3, it is considered low risk. You manage them in a primary care setting. You do lifestyle modification with them. You address all the risk, and you reassess for liver fibrosis in a few years' time. If they are greater than 1.3, you can do a few things. First, you can perform additional tests like liver stiffness measurement, or you can use an additional technique like ELF test, that means another fibrosis score, to stratify their risk. If you determine them to be high risk, you refer them to secondary care such as a hepatologist or gastroenterologist. Our colleagues from endocrinology has come up with an excellent clinical practice guideline, which I should draw on for the remaining of my slide for management, because they actually come up with a really clear and concise and really colorful flowchart for us to use. So I'm going to hijack their slides. All kudos to the endocrinologists for this really progressive CPG. Right, so what do we do? Okay, if your patients have normal ALT and AST, you repeat the ALT and AST annually. If the liver function is elevated, you get an ultrasound abdomen to diagnose fatty liver or to exclude focal liver lesion, and you repeat it after 3 to 6 months. If they remain high, consider referral to gastroenterologist or hepatologist. Using FIB-4 scoring, if your FIB-4 score is less than 1.3, you repeat every 2 to 3 years while addressing their risk factors. If the fibrosis score, if FIB-4 score is greater or equal to 1.3, you refer for liver stiffness measurement, any of the center that's available, or you consider referral to gastroenterologist or hepatologist. This is another great chart from the CPG for type 2 diabetic patient. So again, if the elevated ALT and AST, you use ultrasound to diagnose fatty liver and exclude liver lesion, and exclude other causes of elevated ALT and AST. Use the FIB-4 index to stratify them, less than 1.3 or greater than 1.3. A liver biopsy may be needed to definitely diagnose NASH or advanced liver fibrosis in some patient, or to exclude other chronic liver disease. They may even have concomitant viral hepatitis or other type of liver disease. And when you send them for liver stiffness measurement, you will get reading like this. I just want to point out that you need to know the local cutoff value. For example, the machine in our center is not as high as this. Our cutoff is 7.1, and for cirrhosis is 10.5. So these are different cutoff value, but the principle is the same, that the lower the value, the more unlikely to have advanced liver fibrosis. And when you have increased value, you need to consider referring to gastroenterologist or hepatologist. This is my last slide, you're glad to know. Okay, before I go, I just hope that you had the chance to learn of some tools to use in your clinic, and also a referral pathway, which I will still put up at the end of this talk again. But before I go, I just want to highlight a few things. Firstly, whatever we do, we still need to remember lifestyle intervention is and will always be the mainstay of treatment for MAFLD. Whatever it is, they have to do the basic. They have to lose weight, they have to exercise, they have to watch their diet, they have to stop smoking, so on and so forth, treat their high blood pressure, so on and so forth. Lifestyle intervention is still the most important things that you can ever do for your patient and for them to do for themselves. The other thing is that statin should be prescribed for treatment for hyperlipidemia, dyslipidemia in NAFLD patient when indicated to reduce the risk of CVD. There is a fear among non-hepatologists to use statin, especially when the ALT is slightly on the high side. But statin should be used for treatment of dyslipidemia. And thirdly, if you have to use a drug for diabetes in obese diabetic, the GLP-1, the glucagon-like peptide 1 receptor agonist like liraglutide, or the sodium glucose co-transporter inhibitor like dapagliflozin or empagliflozin is preferred because they encourage weight loss, they induce weight loss and not weight gain like some other anti-diabetic treatment. So I just go back to the slide that this is a very simple slide again, and then this slide I hope will help you. But if you like this slide, you can always download the CPG, the Clinical Practice Guideline, from available on their website. This is the end of my talk. I'll be happy to answer any questions.
Thank you so much, Dr. John Cheng, for the interesting updates. We have received few questions from our viewers today. So I will read the first question. This one is from Dr. Nagaratnam. Is fatty liver index an accurate screening tool for metabolic associated fatty liver disease, doctor?
Sorry, can you repeat that?
All right.
Yeah.
Okay, sure, no problem.
Yeah.
Is fatty liver index an accurate screening tool for metabolic associated fatty liver disease?
Fatty liver index, okay. There are many tools for use for the non-invasive tools, but the important things that you need to consider is that whether this has been validated locally. We use FIB4, although it does have its limitation, because it has been validated locally and with good results and with good negative predictive value. So if you have to use one, I would probably ask to use the FIB4 for fibrosis, to detect fibrosis.
All right, next one, doctor. This is from Dr. Ko Leong Hin. FIB4 score, what is the link of platelets in liver fibrosis assessment, doctor?
Okay, that's a good question. We think that the platelets is related to advanced liver disease. As you know, when liver disease gets more advanced, the platelets dropped. So that is the link between the platelets in the FIB4 and the fibrosis score, fibrosis staging.
All right. Next one also from Dr. Kaur. If rated low risk with normal liver enzymes, can the fatty liver be reversed?
Okay. Now, it depends on what you mean by reverse. My experience is that the fat, there will be always a certain amount of fat there. So if you do ultrasound, say every 6 months or a year, you will probably still see the fat there. But the greatest reversal of fatty liver, let's say those that I follow up and I scan myself, I will see the brightness decrease over time, greatest in people who have lost weight. And weight loss is the most effective way to get rid of the fat. Whether you will get rid of all the fat, I don't think so, but you will get rid, you can probably see, if you remember what they look like objectively, you can probably see it progressively get better as you follow them as they lose weight. Yeah.
All right. And question from YouTube viewers. Why is platelets count used in FIB4 count?
Sorry, I think I've answered that just now.
Right. So we go for the next one. What is the different biopsy like in NASH and alcohol-related hepatitis, doctor?
Okay. They are very similar. That's why NASH or non-alcoholic steatohepatitis mimics alcoholic steatohepatitis histologically, and that is why in the beginning the main difference is that you have to have a history of no alcohol or low alcohol consumption.
All right. Next one, doctor. Can NAFLD without abnormal FSL?
What is FSL? Sorry, where is that?
You can see from the comments in the YouTube.
Can you explain what FSL is?
Okay.
Okay.
Then we proceed for the next one, doctor. How frequently should HPV ultrasound be repeated in MAFLD?
Okay. There is no hard and fast rule. I think it depends on whether there is an indication for ultrasound to be used in the first place. Personally, if I see them, I will probably do it at least once every year. If there is indication to do more, maybe 6 months, but a year would probably be a good interval.
Thank you, doctor. And for the question just now, which is with the abnormal FSL, can you explain what is the FSL so that we can ask Dr. John Cheng for that question? Oh, sorry. There's Dr. Naga said it's fasting serum lipids.
Okay. I'm so sorry. So the question is, can NAFLD occurs without abnormal? Yes. You can see that that's why you can have at least 2 of the metabolic syndrome criteria. You don't need to have all of them.
Thank you so much, Dr. John Cheng. I think that was the last question we have for today. So do you have any last remarks for our viewers today, Dr. John?
I'm just glad that I have the chance to increase awareness of this MAFLD, because in my mind, in my experience, it will be one of the biggest things that the medical fraternity have to grapple with. As lifestyle change, as people become more affluent, become fatter, diabetes get more common, this will be increasingly contribute to our workload, whether you are in in primary care or in secondary care. So I hope that today I would have put some information and some tool in your hands to start screening your own patient where you are. I wish you the best, and I wish you a very productive year ahead.
All right. Thank you once again, Dr. John Cheng. To all our viewers out there, I would like to bring your attention to the flyer on the screen. For your information, shear wave elastography or fibroscan is now available at Gleneagles Hospital, Kota Kinabalu. It is a non-invasive, quantitative assessment of the degree of fibrosis or presence of cirrhosis in liver. Fibroscan is quick, painless, and risk-free. By using it, we can reduce the need for biopsy and get a more accurate diagnosis and be able to monitor changes in liver disease. If any of your patients need this, you can refer them to Dr. John Cheng. Next, for all doctors, please don't forget to scan the QR code at the end of this live by using your MMA Dr. Phone application to get your CPD point now. If you have any difficulties to scan the code, please click on the link for doctors only in the comment section to confirm your attendance manually. And to all the Gleneagles Hospital Kota Kinabalu staff who are watching this now, please don't forget to click on the link which is specified for GHKK staff only in the comment section to confirm your attendance. Please make sure you click the correct link for your attendance. And also, we have another online CME session with our Sessional General and Upper GI Surgeon, Dr. Uwe Wei Kiat, on the topic of understanding the upper GI tract biopsy reports for primary healthcare physician on 30th of April at 6 p.m. Let me know if you are interested. We will share the details with you. So we have come to the end of our online CME today. Thank you very much for watching and see you next time.